The reason I'm concerned about this, and Dr. you'll weigh in on this, is because Africa, and specifically sub-Saharan Africa, is one of the areas that bears the hugest disease burden. In fact, the weight of the global disease burden, we carry a big chunk of it as Africa. That's why it's important for us to rethink how we look at our health system. How much do we invest? Do we have the right people? Do they have the right skills, the right equipment to use to be able to serve the health needs that we have as a continent? In your conversations, I know the institution you represent really looks at the standards that must be met, the threshold for one to be a nurse. Do you flip the coin to look at how much they get also in terms of reward for what they put in terms of training and in terms of the long hours that they work? As we celebrate nurses, what is the status of the conversations that are going on around addressing some of the challenges that Collins here has spoken on behalf of the hundreds and thousands of nurses out there?
Okay. Thanks. The conversations of e-migrations being within the Africa region, Kenya, of course, we are the Africa, and we love our Africa that we want, is sustaining or mitigating the immigration or migration issues within our fragile health systems is maybe a little bit complex and challenging. But we acknowledge the fact of where are we coming in as a country, and even as nurses and the professions. Yes, indeed, there's a lot of challenges and issues basically surrounding the issues of the retention, issues of the migrations and all that thing. But I think the conversation there in regards of us as Nursing Council of Kenya, who we are mandated, and you put it rightly, to be able to uphold the standards of midwifery and nursing educational practice and to ensure that the standards are met. And when I said about the standards, is even that what is the minimum standards that the nursing care should be provided, which I had alluded earlier that if a woman is giving birth, bare minimum, we need 2 midwives, and moving forward on that. But conversion has been done because we are part of the development of strategies and also policies that they favor the nurses and among other healthcare provisions. So first is to have a conversations, and this conversation we've been able to do, even what Collins mentions, that we have been in the forefront to develop career progression guidelines, which we used to call them scheme of service. He has referred to that. And when we talk about that, we just said, when we have the certificate nurse all the way to the masters, to the PhDs, which we already have. I, as Edna, of course, I am a nurse and a midwife. But how do we just ensure that the scope of practice, what they are limited to be able to do, is translated to their job descriptions, to their competencies, and that again is attached to a salary and also a pay and the roles. So that is what we have been advocating to be able to invest in that. Again, is improving working conditions. Bare minimum is that we've been able to develop the standards of practice. During COVID, we reviewed what should a critical care units be, how many nurses, how many doctors, how many clinicians should be part of that conversations, and even to ensure that we have our nurses who have specialized at higher levels, from higher diploma to the masters, and that be part of healthcare system. Unfortunately, Safina, we've not been able to employ, especially our masters, even our bachelors within that. We are still far from ensuring that if we have 20 nurses, we have 3 with diplomas, we have 10 with bachelors, and we have 20 above that. Again, is also issues of professional development opportunities. The good thing, Safina, is that we have been able to make progress in nursing and midwifery, and we've ensured that we have programs that it will be able to support nurses to still continue working, especially tapping on the ICT infrastructure, where we have our e-learning platforms within our institutions, and they are able to balance the work that the nurses are able to do. If, for example, you are family, you have a job, you are able to go to schools and move there. But again, the issue which we are having conversation, and even as we talk this morning, we just want to urge all the employers in our institutions to provide learning institutions. And when I say learning institution, is that we have dedicated and protected time for the nurses and midwives to be able to go to school, to be able to learn, because those are part of the push and pull factors that Collins alluded earlier, that these are the things that it pushes our nurses to go to immigrate. They are able to balance their work, their families, and their educations. Again, is to provide incentives for the nurses to ensure that we facilitate the transfer of knowledge. When someone goes to school and comes back with a certificate, whether it is a year, whether it's a 2 years, it should be able to be remunerated first, to be placed in where they're supposed to be placed. And we've always advocated as Nursing Council of Kenya, if we go to a facility where we have a critical care nurse placed perhaps in an orthopedic department, we always actually advocate to the institution and tell them, please make sure that you deploy this nurse to where that they can be able to utilize their potential, because we really need to unleash the potential of the nurses. We need to ensure that whatever they are trained, they are able to work on. But what is a little bit constant is that ensuring that we have good investment, especially in finances, to be put within both the national and county government for them to be employed, for them to be retained, for them to be promoted.
All right.